My name is John Hibbs. I'm the National Sales Manager for Contamac US, and I am very excited to talk to you and allow that this presentation is being brought to you by our company. Contamac is the largest contact lens and IOL materials producer in the world. Contamac materials in the GP line are the optimum materials. We also have the definitive Sci-High and IOLs. The U.S. authorized laboratories distribute our materials, and Optimum is the top choice for over 15 scleral designs in the U.S. marketplace today. We're very excited that we have just been awarded our second Queen's Award for Enterprise and Innovation just this year. This is one of the top awards that's given not only within the United Kingdom, but it's recognized as one of the top awards given throughout the world, and we have received two of them. We're very, very excited about our accomplishments. We're one of the fastest growing GP manufacturers also within the domestic marketplace. With that, I would like to go ahead and transition over to Dr. Steve Burns in today's webinar. Dr. Burns is in private practice in Londonderry, New Hampshire. He also has taught at NECO, and he speaks throughout the world. So I hope that you enjoy today's webinar, and we'll have some questions at the end. Thank you again for attending.
Thank you for inviting me to present this seminar, John. I've been involved with fitting scleral lenses for over 10 years. I don't remember the exact date, but when I got started, between 10 and 15 years ago, there were only a few commercially available scleral lens designs, and I started working with one of the designs actually before it became available in the United States, and I've been involved in scleral lens design and development and fitting since that time. So today what I want to do is share some of the information, some of the knowledge that I gained over that period of time. Now remember, when I started fitting lenses to my worst patients. I started using the scleral lenses. Whenever we get a new device, the first people we like to try it on is the patient we can't fit it with anything else. And surprisingly, scleral lenses really fill the gap here. As you can see in this patient who has an advanced cone, we're able to vault over the cornea and give this individual a new refracting surface that allows him to see a lot better than what he was seeing with any of his previous corrections. In fact, this person had a difficult time managing a corneal contact lens, trying to get but scleral lenses, the way they're frenia in the limbus and they align to the conjunctiva and sclera, we're fitting safe, healthy tissue, and we actually got some very good results. So today we're going to talk about some issues that I got as we were going along fitting. And in the process of fitting, you have to learn some new skills. One of the things is, how do you judge your fit of a scleral lens? Well, if we take the tools that we used when we were fitting corneal gas-permeable lenses, we basically fit the lens looking at fluorescein patterns and lens movement. These lenses are very big. They really don't move on the eye, and the fluorescein pattern is quite different than what we'd see with a corneal lens. Because the lens is vaulting over the cornea, as you see on this lens picture on the left, I'm looking at that eye with cobalt blue light and yellow barrier filter on my slit lamp, and I can see that I've got a lot of clearance centrally. I might have a little bit of minimal clearance at 1 o'clock, and then you can see on the conjunctiva sclera, particularly right above that, you can see a darker zone. So that's where the lens is aligning on the fit. Now I can't tell what my depth of that fluid layer is unless I use an optic section. And when you're using an optic section, you don't use the cobalt blue light or the yellow filter. You use white light, and you turn the light up to the highest intensity that you can with your slit lamp, get it nice and fine, and look at it from about 45 to 60 degrees to look at a optic section through the cornea, through the tear lens, and through the lens. And you can see that you can visualize actually the lens itself, the front and the back surface, the fluid layer, and you see that the fluid layer diminishes superiorly here as you follow my cursor. That doesn't mean there's any fluid, there's no tear layer there. It just means that this tear layer is less than 20 microns. Once you get less than 20 microns in your tear layer, it's difficult for the human eye to pick up the fluorescein. Now, also, what I found in the process of fitting lenses is that it's not unusual to get a lens that sags down or a little bit on the cornea, and when you look at the lens on the eye, you'll see that you don't have quite as much coverage of the superior sclera as you do the inferior sclera. And that's because gravity is actually pulling this lens down a little bit. In my 12 to 15 years of fitting these lenses, I've never had an area of staining occur here from the lens as it slides down, because if you have the patient look down and the lens gets pushed up by the lower lid, you'll see that you do have clearance there. And we'll be looking at that again a little later. Now, when I fit a patient with scleral lenses, the way I first started was I just took a lens from the middle of the set, and I put on the fitting set. You do need a fitting set fitting these lenses. And I put the lens on the eye. Now, my initial fitting set had lenses every 50 microns, and I had about 40 lenses in the set, and there were far too many lenses for fitting. It was fitting on sagittal height. I really don't need that many lenses to estimate the height of the cornea. I just need to be able to put a lens on that vaults the cornea and the limbus and then evaluate the fit. Now, if we look at, I have three eyes here. Actually, I drew this the other day, and I'm representing the cornea as this section of the curve in front of the straight line. Consider at the straight line the juncture of the limbus, and I just duplicated those three curves and straight lines, and then I adjusted for scleral shape, because scleras have different shapes. This sclera is fairly steep. This one flattens, and this third eye, the sclera flattens even more. Then I took a lens which was the exact same curve, and I just changed the color of it, and I call that my contact lens. And the contact lens comes down and it touches the sclera, and we create some vault or distance between the cornea and the contact lens. Now, if I go down to the, well, here what I've done is I flattened that lens in the periphery superiorly with a fitting curve. So now the lens aligns to the conjunctiva and sclera, and the vault of the lens decreases because I've decreased the overall sagittal height. Now, if I take that same lens without a fitting curve, it vaults even more greatly over this cornea. I put a flatter fitting zone on, and the lens now has a similar sagittal height away from the cornea as the first lens. The third lens, the third eye, I put the same lens on, and I get even greater sagittal height. By fitting this eye with a flatter peripheral fitting curve than the other two, I'm able to get that similar type of corneal vault over the lens. So there's two parts to fitting the lens. It's vaulting the cornea and the limbus, and it's aligning to the conjunctiva and sclera. And now you have to do that 360 degrees. And how do we look at the fit? Well, The best way to look at the fit is either with diffuse illumination, so I'm really using diffuse or indirect illumination to the right and to the left of the beam, and I'm looking at these small conjunctival vessels, and I see that they have no impeded flow from the inner chamber out to the conjunctiva beyond the lens. And here I can see within the area where I have the optic section, I can see the lens thickness itself as it falls over the conjunctiva. But right below that area, I really can't see the blood vessels because the brightness of the light blanches out the appearance of that, particularly with photography. So we evaluate the landing zone 360 degrees, and what we ultimately want is an area that looks like this, no impingement. Now occasionally we get a little bit of impingement in small areas, and that might not be a problem. But if we have a large area of impingement, that necessitates us refitting the lens if certain conditions apply, which we'll talk about. Now let's transition into the patient's issue with contact lenses. To us, fitting scleral lenses, when we initially get started, everything is new. To our patients, every time they get started wearing these lenses, everything's new. These lenses are handled entirely differently than corneal gas permeable lenses and corneal and soft contact lenses. The lens needs to be applied to the eye in a manner that we keep fluid in the bowl. So the patient looks down, they look at the center of the lens, or they look at the center of the holder that's holding the lens, and they place the lens gently on their eye. And the lens should as it's applied to the eye, fluid should remain behind it. If they look off to the side, or they have difficulty putting the lens on properly, they're going to introduce a bubble. Here's a bubble underneath this lens on the left, and here's a couple of bubbles in the behind the lens on the right. There are two difficulties with bubbles. One is if the bubble gets into the visual axis, it's going to cause problems with your vision. You're not going to have good vision. It's like looking through a fogged up window. But two, the lens also, where the bubble is, the lens, the surface of the cornea will start to dry out because there will be no moisture where that bubble is. And the longer the bubble stays there, the more corneal drying you get. And the sensation that the patient gets is burning and stinging, and then a burning type of pain, which keeps increasing in intensity and is not comfortable. And so if the patient comes in and they're telling you that their lenses aren't comfortable, and you look at the lens fit and you see that it's a pretty good fit, then you have to start delving into, well, do you get bubbles behind your lens? In fact, patients have a difficult time seeing small bubbles like these behind their lenses. Using a magnifying makeup mirror that's illuminated will help them see the lens on their eye without the help of a presbyopic correction if they needed that. But unless, if the bubbles are off to the side, they can be missed. So I tell my patients, if they're feeling burning or stinging that starts about 5-10 minutes after they put the lens on the eye, they have a bubble, take the lens off and replace it. Now, they may have to reinsert that lens or reapply that lens 2 or 3 times before they get it right. But them when they're starting out that this is normal, and as they get used to handling the lenses, they're going to improve. Now, the second thing that I learned after fitting the lenses for a while was, well, when you take the lens off, it leaves a little compression ring on the conjunctiva. This is normal. The reason the lens leaves a ring is we know that the conjunctiva is soft. The cornea is hard. Hard lens can imprint onto the cornea somewhat, as we see with orthokeratology. But a rigid lens, scleral lens, can imprint onto the conjunctiva, which is much softer and spongy. And when we take the lens off, we can see an imprint, particularly if we put fluorescein on the eye. We can see an imprint where the lens was. In fact, you don't need to have the fluorescein. A patient will remark to you, well, when I take the lens off, I see this ring on my eye. Is that okay? Well, avoid that conversation by telling them initially, look, this lens fits on your conjunctiva, which is soft. It's going to settle into the conjunctiva. When you take the lens off, you're going to see a ring of where the lens was. That ring will go away within the next half hour. But if we look at this ring, let's look at it for information. This is compressed in a little more than where it is superiorly, and nasally is compressed in even more than that. Inferiorly we don't see, but it was similar to the superior zone. So this is telling me that the horizontal meridian is flatter and the vertical meridian is steeper. And in this instance, I can try to match the pressure of the fitting zone on the lens 360 degrees by using a toric fitting curve, fitting flatter in the horizontal meridian and steeper in the vertical meridian. So here's a video of one of my patients where the same patient actually, where I'd taken the lens off, and you can see that you get a little bit of a compression ring, more nasally than temporally. Look right here, that little zone. Let me see if I can go back to that. Right here, that zone where you had a little bit of redness. That would indicate to me a little too much pressure there, and that could be the source of discomfort. So this patient might be complaining about discomfort after wearing this lens for a while. Not right away, but maybe after 3 or 4 hours. And sometimes they find that the following day it's more difficult to wear the lens, and the day after that they want to take a day off from the lenses. So if you have too much compression in an area, you can create like a mild episcleritis type of discomfort, and the patient will respond to that by not wanting to wear their lenses, and they'll come in a little dissatisfied. So when you're looking at the fitting zone, you want to evaluate it 360 degrees and look and see, would you be better off with a Sclera, with a toric fitting zone versus a spherical fitting zone? Because an improperly fit lens over the cornea, over the limbus, is going to create pain. And pain with lens wear, you have to decide, okay, where's that pain coming from? It can be coming from the fitting curves, being too tight on the conjunctiva and sclera, or too loose on the conjunctiva and sclera. If the lens edge is sitting up away from the conjunctiva, it's going to be felt by the eyelid, and that's going to be a source of chronic irritation. If the lens is settled evenly into the conjunctiva, the eyelid goes over the lens and the conjunctiva, and it's not felt. If it's impinging in a certain zone on the conjunctiva, then it's going to create discomfort again. Patrick Caroline, Tina Graft, Eve van der Werf, and Randy Kojima did a very interesting study. They took 48 subjects, they had 96 eyes, and they used an OCT to measure the angle of the sclera at certain distances away from the apex of the cornea. And so what they did was they measured the scleral angle at 10 to 15 millimeters away from the apex of the cornea. They're actually measuring chord 10, this is 5 millimeters in length here, so going both sides it's 10 millimeters, and then they did a chord at 15 millimeters, and they measured the angle here compared to the cornea. And what they found was the closer you are to the limbus, the more symmetrical the sclera is, but it's not perfectly rotationally symmetrical. There is some asymmetry to it, and as you go further out, that asymmetry gets even greater. So the take-home point from this is that you want, if you want to have a lens that you can fit with a spherical fitting zone, try and fit a lens that's not that large compared to the horizontal visible iris diameter. But if you want to have a toric fitting zone, and sometimes you do, to stabilize a lens that needs a front toric cylinder correction for residual astigmatism, then you may want to fit a larger lens. needless to say, you want to look at the compression ring when you take the lens off. Look at 360 degrees. Is it even? Is there one meridian or one quadrant where the compression zone seems to be a little deeper? Have the patient rate the lens comfort on a scale from 1 to 10. 1 being terrible, they can't tell the lens is on the eye. 10 being so perfect, they don't know it's there. If the lens comfort is between 8 and 10, and there's no conjunctival staining, but you do have a compression ring, do nothing. The lens is fitting fine. That's normal. If the comfort is less than 7, you may want to think about redesigning that lens. Look and see if a toric or a quadrant-specific fitting zone would be appropriate, or if they need to have an actual flattening of the zone all the way around. If there's significant conjunctival staining, not fluorescein pooling, you may need to have the edge of the lens polished because that lens edge might be a little sharp. It might be actually causing a little laceration of the conjunctiva. So be aware of that. Patient with a toric peripheral fitting zone. The flat meridian is designated by, in this case, 2 X's marking the flat meridian. Now, what we can do is look at, first off, we see full fluorescein coverage, and as we look around beyond the limbus, we can see the fluoresceins going beyond the limbus. Then we look at the conjunctiva, and we look at those blood vessels. Sorry about that. We look at the blood vessels, and they look quite even and full. There's no areas of blanchings that are seen. So this is a lens that's fitting well on the conjunctiva and sclera and vaulting the cornea and the limbus. We don't know by how much looking at this, but we do know we've got full vault. Now, if we have take the lens off the eye and we want to say, well, the laboratory said they put toric peripheral curves on this. How can I tell? Put the lens on a flat surface and look at it from the side. And you'll see the areas where the lens peripheral fitting zone is flattened actually lift up away from that surface, showing you that you've got a toric fitting zone on that lens, and that's where the fitting zone is. So here's a problem. When we put a lens on the eye, what happens if there is not a meridian of impingement, but just a small area? Here's a patient that has a conjunctival bleb right here at 6 o'clock. And the patient was wearing the scleral lens, and you can see the compression ring slightly, but over the bleb, we're getting conjunctiva that's actually saturating into the conjunctiva. We actually have a mild conjunctival abrasion here from the edge of the lens. What would we do to improve the fit on this patient? Well, as I told you, as we go further away from the limbus, further out, according to the study by Graf and Caroline, we get more toricity. But it doesn't need toricity. This needs a lens that avoids that area or covers the area. So there are a couple of things that we could do. We could decrease the lens diameter to avoid the conjunctival bleb, and so that would be going to, maybe if that's a 16 millimeter lens, going to maybe a 14.5 or a 15 millimeter lens. We could increase the lens diameter to vault over the conjunctival bleb. So if that's a 16 millimeter lens that was on the eye, maybe go to a 17 or an 18 millimeter or more lens. And if you don't want to do one of those two choices, you could also take the existing lens and have the laboratory put a notch in the lens. What I would do is, while the lens is on the eye, I would draw with a Sharpie pen the area that I wanted to be notched so they know how wide and how deep to go into the lens. The problem with notches, though, is that they do decrease the structural stability of the lens, and so you could have a higher degree of lens breakage. The fourth thing you could do is do nothing but follow that area carefully. If you have chronic irritation there, I would recommend you go to steps 1 or 2. Here's a patient that came in, and the comfort of the lens was a 10. But the patient has this long thread or hair that is trapped underneath the lens. It's not only underneath the lens, but it comes out onto the conjunctiva here also. The patient is totally unaware of this piece of debris behind the lens. And I've seen eyelashes floating in the chamber. I've seen different colored threads. I've seen people who've just had haircuts that have little debris trapped behind the lens. The lens acts like a bandage, and really there isn't a lot of movement. And so this little foreign object is stabilized here, and it's not moving around. The patient doesn't know it's there. So surprisingly, you can have unusual debris trapped behind the lens, and it's like being in a swimming pool. So what are some of the problems that I've seen? Okay, there's problems with the conjunctiva. I break them down into two colors. The problem is red, or the problem is white. Something that's red, conjunctival hemorrhage or subconjunctival hemorrhage, that's usually a handling problem, where the patient accidentally takes the lens off too roughly and causes a little break in one capillary, and you get some blood being trapped in that loose space between the conjunctiva and the sclera. We all know that that is something that looks terrible but goes away over a period of time and doesn't require any concern. But we can have conjunctival congestion and conjunctival inflammation. Both of those require our attention. And how about if the conjunctiva is white? That means that the blood is being pressed and blocked from going into the area of the lens where the lens is white. And that could happen at the compression ring, or it happens along the fitting zone of the lens. And then adjacent to that, on the inner side, the conjunctiva can actually be billowing or pulled in and trapped at the limbus, and that can create some interesting pictures for you. Here's a person that has conjunctival blanching. Now, conjunctival blanching, when I see it 360 degrees, I consider that the lens has probably been applied to the eye with too much pressure. And when it's applied with too much pressure, you create a negative pressure chamber behind the lens, and the lens is actually sucked in towards the eye. And that creates more compression over the conjunctiva, blocking those tiny capillaries and giving you the impression that, well, the fitting curve is too tight. Well, it's the lens overall is too tight, and you have to talk to the patient about gently applying the lens to the eye with minimal pressure, if any. And also tell the patient to avoid rubbing their eye, because pushing on this on the lens will push fluid out and will also create that negative pressure. If you look here, as we go to the horizontal meridian, it seems like we get less injection. So this could be that we're a little flat in this inferior meridian, and maybe a toric fitting curve could improve that situation. So if you see blanching 360 degrees around the lens, or if you're a laboratory consultant and one of your clients is calling saying that they're having this condition with one of their patients, the first thing to do is re-instruct the patient on lens application. The next thing is, if the lens was just applied to the eye by the practitioner or the patient, wait 15 minutes, allow the lens to settle, because sometimes if you put the lens in with a little too much force, but it's not that bad, the lens settles into the eye, the condition automatically goes away. If you see blanching that's consistent and it's in one quadrant or two quadrants, you need a toric fitting zone. If the patient is looking in primary gaze and you don't see any blanching, but when they look up, all of a sudden you see blanching inferiorly, and when they look down and you're looking at the fit of the lens and you see blanching superiorly, that's gaze-induced blanching. When the patient looks back to primary gaze, it goes away. You ignore that. That's nothing. Here is a problem. This patient has not only blanching, but congestion and inflammation. If you look inferiorly from 7 o'clock down to about 530, you have a zone, a Furrow zone with impingement at the very edge of the lens. But if you look at 9 o'clock and over at 3 o'clock, you don't have any problems there at all. This lens is impinging and it's too tight in the vertical meridian. This lens needs to be flattened in the vertical meridian, yet the horizontal meridian can stay the way it is. You have blood not being able to return, outflow, being trapped underneath the lens between the limbus and the edge, and that's congestion. And outside that, you have some angry blood vessels, that's inflammation. So it's an unacceptable fit, and this lens does need to be refit. Patient will adapt to that and won't. They should be fairly uncomfortable with that fit. So zone in the vertical meridian, and when we flatten the zone, we're going to take plastic away. So that lens is now going to fit more closely to the cornea, and so we need to pay attention to the corneal fit, the vault of the cornea, and adjust it if necessary. So moving on, what happens if your patient falls asleep with these lenses? My patients often ask me, are these lenses okay to take naps in, to sleep in? I wear the lens myself, and I'm one of the people in this picture, and I've fallen asleep after having this in-depth conversation with my older brother, who has some very interesting things to say. And it just put me to sleep, and I'm wearing lenses, and when I woke up, everything in the room was foggy. Yes, these lenses have high decay, but the decay over T and the thickness of the fluid layer minimize the amount of oxygen that gets through to the cornea. So these are not lenses to be used for extended wear, and even short naps can be a bit of a problem. So when you get edema, what does it look like? Well, one of the things is, if you look back in history, and we go back to when we were all fitting hydrogel lenses, and some of the hydrogel lenses were pretty thick, we would get what's called furrow staining, which was first described by Tony Kahane and Barry Weissman back in 1996. And they questioned, should hydrogel lenses be used if we're getting this furrow staining, which they found is a sign of corneal edema. And you won't be surprised with some of your lens fits that, particularly lenses that may have a little added thickness and have a greater vault over the cornea that you may really want, but you need to have that type of fit due to the shape of the cornea, you may find that you are getting some furrow staining. So I advise you to use fluorescein after you've taken the lenses off and look at the peripheral cornea, look at the limbus, and see if you are developing some furrow staining. It's a sign that the patient isn't getting as much oxygen as we like. So what can we do about that? Well, one thing you can do is have them decrease the hours of lens wear. Maybe give themselves a break during the middle of the day. Or maybe you can improve the decay over T by thinning the lens design or increasing the material's oxygen permeability. So if you were fitting a patient with the Optimum Extra, maybe go have the lens remade in an Optimum Extreme. And maybe at the same time tell the laboratory that you want to have the overall thinness of the lens, thickness of the lens decreased. Look at the fluid layer. Can you decrease the fluid layer thickness by either lowering the sagittal height or decreasing the clearance in the mid-periphery and periphery? Or you can do nothing but closely monitor for signs of neovascularization. So I'd say have that patient back every 6 months to make sure you're not getting an issue with chronic deprivation of oxygen. Here's another patient who has furrow staining and also has the conjunctiva pulled in a little bit. I call it conjunctival tenting when it's over the limbus and against the corneal epithelium. It's called conjunctival prolapse. And here's a patient with even more significant conjunctival billowing or prolapse or tenting over the inferior cornea. Now this patient also has conjunctival chalasis, or she has redundant conjunctiva that, as you watch without a lens on the eye, you can see it fold up along the lower lid and sometimes present with similar symptoms to dry eye as it impedes the tear flow of the tears in the blinking action. Well, anyway, if you've got a lot of excess conjunctiva, the lens with blinking have a little bit of a suction effect, and they pull tears in, and they can pull conjunctiva in and debris in also. And here the conjunctiva is being pulled in. Is it a problem? Well, I've been following this patient for about 10 years, and she hasn't had a problem. But Pat Caroline and Mark Andre reported back in 2013 of a patient that they had with conjunctival prolapse, and the conjunctiva started to adhere to the corneal epithelium, creating a problem that we probably don't want to have. Well, I see, how can we avoid this? Well, one way is, can we redesign the lens to have less clearance in the periphery? Maybe we can, maybe we cannot. Can we use something other than saline to lubricate the surfaces? Yes, we can do that. An artificial tear, non-preserved artificial tear, can be used instead of saline, and the lubricity of the artificial tear will keep the two surfaces from actually sticking together, and so that would be my recommendation. So again, with these patients, we monitor them a little more frequently, maybe every 3 to 6 months. If we can, we might want to try to redesign that lens periphery, but you'll still probably have a problem because of the excess conjunctiva. You may need to go to a surgical repair of the conjunctival chalasis. Another thing we could try would be going to a much larger lens and trying to move the fitting zone further away from the limbus. And here's another case. This patient came in and having no problems. Actually, the patient's a dry eye patient and was fit with the lens to help keep the cornea and the conjunctiva and the limbus hydrated. And the patient found the lens to make life a lot more comfortable. However, the patient did say that her eyes still seemed to be quite red. And when we put some lissamine green stain on the eyes, we found that that area of conjunctiva stained with the lissamine green, indicating that for sure there is some dryness going on. Well, this isn't the problem exactly with the lens, it's a problem with the eye. You should instruct your patients, if they have dry eye, that they still may need to use artificial tears. They don't get burning or stinging like they do when the cornea is dry, but they still have, one of my patients described it as feeling like wintergreen, where the eye was would feel like the conjunctiva was cooling. Well, that's evaporation. So perhaps artificial tears, perhaps we use punctal plugs to retain the existing tears. Maybe we want to use a larger scleral lens to cover more of the conjunctival area. But remember, as you go further out, the fit becomes a little more complex, and you may need to go to quadrant-specific or toric fitting zones. Or, then again, we may do nothing, or the patient may do nothing, and again, we just monitor the patient to see if long-term anything is happening. But for sure, the patient is more comfortable with the scleral lens because their initial dry eye symptoms have gone away. Another problem that I see very infrequently, but it does exist, is contact lens-induced papillary or giant papillary conjunctivitis. And this is a problem that's due to the lens not being kept clean. The lenses get coated with protein, and you need to use a little bit of elbow grease cleaning your lenses every day to remove the protein. I used, for the first, I started out using primarily the all-in-one solution, Simplus, and I found over the long patients, the majority of patients didn't keep their lenses clean adequately with that. So I added a periodic use of a specific lens cleaner, or changed them to peroxide and added the lens cleaner over a period of time too. So what do you do about the giant papillary conjunctivitis? Well, you treat it as you would treat any of the, if the condition were created by a soft lens or a corneal hard lens. You give them the appropriate medication, but then you teach the patient this is an expensive lens to replace on a daily basis. We're not going to do it, but the lens surface can be cleaned. Teach them how to fully remove the coatings and how to be able to tell if the lens is coated by feeling the surface of the lens. If the lens surface is sticky, that's protein on the lens, and it needs to be cleaned until the lens surface feels smooth and silky. Maybe you might want to offer the patient the opportunity to come into your office periodically and have one of your staff members clean the lens with a more abrasive type of cleaner. Or if the lens design is the cause, if the edge of the lens is maybe fit a little too high and is causing irritation to the lid, you have to redesign the lens. Another issue that we have is what happens to the tears. The tears can bring in particles that get trapped on the lens. They can bring in different types of contaminants that get into the tears, and unfortunately the lens materials do have a propensity for lipids and proteins to coat on them. Now fortunately the optimum materials are more wettable, and I see this as a less frequent problem, but there are some patients, particularly women who use a lot of makeup, or people who use moisturizers in and around the eyes and on the lids, and these products actually can flow on the skin, and they leach into the tear layer even when they're not put directly along the lid margin. So this is a difficult problem because it's hard to tell a woman not to wear her makeup, and if they need moisturizers, it's how do you judiciously apply it. So this requires a little bit of conversation time and maybe some investigation as you help the person determine which product is the offending product. So what do you do about this? Well, teach the patient. When I teach my patients how to clean the lens while it's on their eye. I tell them to get some clean Q-tips, put them in a little Ziploc bag, and bring that bag with them when they go to when they're going out on the day, and maybe keep a bottle of a conditioning solution, artificial tear, or multi-purpose soft lens cleaner in their pocket or in the bag with it, so that they can moisten the end of the Q-tip and clean the lens on the eye. I'm going to show you how that's done. Next, you can tell the patient that they have to clean the lens. Take the lens off, clean it, recondition it, reapply it. And they may have to do that 2 or 3 times a day. See if you can determine which skincare or makeup product is causing the contaminated tears. Sometimes you may have to redesign the scleral lens, decrease that lens vault, because that space between the contact lens and the cornea fills with fluid, and if the fluid's filling with debris, as that debris increases, that fluid layer becomes milkier and foggier, and that becomes a source of not irritation, but it affects the visual acuity. You may have to remake the lens. If the lens has an edge that is causing chronic irritation, causing more mucin to be excreted by the goblet cells, you may need to redesign the lens. So here's a patient wearing a lens that is not wetting properly. And the lens, if the patient was dispensed on the lens and the lens was wet properly and was working fine, and they come back in and it's no longer wetting well, it could be that they've contaminated the surface with some type of oil, moisturizer, or some other contaminant, and it's keeping the lens from re-wetting. Now in this particular case, we were able to recondition the lens while the lens was on the eye. Here I have a Q-tip saturated with the conditioning solution, and I rub the surface of the lens, and you see the lens is now wetting well. So one of the problems the patient has when they're out and about doing their daily chores, if they have a little bit of a problem, it's difficult to take this lens off. First, wash your hands, have a clean environment, have a surface which you can work over, take the lens off, have the solutions that you need to clean, recondition the lens, and put it back. A lot of that. Q-tips with them and a bottle of multi-purpose solution, wet that, saturate the end of the Q-tip, and just wipe the surface of the lens on the eye. This may be all they need to keep them happy and seeing well. Another problem that we have with some patients is when we fit them with the Scleral lens, we wind up with some residual refractive error. And the first thing to do is, these are patients with quite often with medically challenged eyes, and is the decrease in vision due to the residual refractive error, or is it due to corneal scarring, cataracts, some type of retinal problem, vitreal problem? So the first thing I do is a pinhole test. If the vision improves with the pinhole test, then I do retinoscopy myself, but I guess you could do a auto refraction over the lens, and I look for residual cylinder and residual correction, and then I trial frame that correction and see how well I can improve the vision. If I can improve the vision, the patient has two choices. If it's residual cylinder, I tell them that in order for this lens to maintain that correction in the right position, I needed to have some way of stabilizing the lens on the eye. If I don't have a good method of stabilizing the lens on the eye, I advise them to put that residual correction into a pair of glasses. And quite often people are particularly people where you've significantly improved their vision with just the lens alone, to get that extra increment of vision when they want it, they're very willing to do that. But some patients want to have the correction fully in the lens, in which case we can put a front toric on the eye. But with a front toric, we have to find a way to stabilize the lens. And this is where we go back to Tina Graft and Pat Caroline's study at Pacific University, and we look at, well, if we want to stabilize the lens, what's the best way to do it? And the best way is by fitting a lens that's fit over an rotationally asymmetric sclera. So we want to have a lens that needs a quadrant or a toric-specific design. Probably a toric-specific design is the most comfortable to fit. And so if we fit the lens with a larger diameter, we may be able to get that situation where we have blanching in one meridian, and we need to flatten that meridian. And then we apply the toric correction after. Well, it's usually a two-step process. You have to get that toric lens, put it on the eye, see if you still have the same residual cylinder, and then do your over-refraction and have the laboratory make you a third lens to incorporate that front toric. So when it comes to putting the lens on the eye, what's the best solution to use? Well, there's a number of solutions that we've had out there. We need to use non-preserved sterile saline because we found that if you use a lens solution like a multi-purpose solution that has very gentle preservatives in it, they're not designed to be kept on the eye for 5, 10, 15 hours. The only solution that's been approved by the FDA is the Lacropure by Medicon, and so by that alone, that's my first choice. But I've used Adipac saline, I've used Unisol 4, that's no longer available, it's discontinued, and I use, in certain instances, non-preserved sterile artificial tears when I want to have some lubricity. So non-preserved saline usually allows you to have a very nice clear cornea that's hydrated. The solution that has a preservative in it, brand A or brand B or brand C, they're all going to have some issues. Here's a patient that was wearing a lens, and we're using non-preserved saline, and the buffers in it created this little granular SPK, very fine granular SPK. And so this patient, I switched to a non-preserved artificial tear, and like Refresh Optive, and I filled the bowl, had the patient fill the bowl with that, and the staining is all resolved and the patient's happy. Here's a patient that also has a corneal staining problem, but the problem would develop after the patient wore the lens for a while, after 3 or 4 hours of wear. And looking at the fit, well, the patient had gotten the lens a year or 2 before, and the patient's keratoconic, and the keratoconus progressed, and now the patient was getting a mild chafing of the corneal epithelium where the lens was contacting the cornea during lens wear. Well, the patient had, I advised the patient we need to change the fit of that lens, increase the vault to clear the cornea, and the patient said, well, you know, I don't have insurance, and how much is that going to be, and is there another option? And so what I did was I introduced patient use artificial tears like I did in the example, and by filling the bowl with artificial tears or adding 3 or 4 drops to non-preserved saline, I introduced enough lubricity that there was no longer chafing as the lens came in contact with the cornea there. But again, as we learned from fitting corneal lenses, constant pressure of the lens on the apex of the cornea can lead to corneal scarring. So again, that patient needs to be followed more carefully. Better choice is to increase the sag, but in this case it wasn't possible due to financial issues. So there are potential problems that we have fitting these lenses. We have to look at the decay over tear, how much oxygen is getting to the cornea at the corneal surface, and that's dependent on the decay of the lens material and the thickness of that fluid layer and the thickness of the contact lens itself. Conjunctival prolapse can create some interesting findings, and that's something that we have to follow over time to ensure that we don't get adhesion of the conjunctival epithelium to the corneal epithelium. We have mechanical fitting issues, which we went over, and those all are solvable by design changes. Solutions can become a problem, and that's a need. We need to constantly monitor that with our patients, because patients can go out and buy the wrong solution thinking that they're doing the right thing and come in with problems. Lens surface contamination is one of our biggest headaches. It requires a lot of time sometimes in determining what the cause of the contamination is, but it's a necessity to address that and to keep our patients happy, give them options of how to clean the lens, and try to figure out what's the offending contaminant. Debris in the fluid layer. If we keep our fluid layer thin, it's probably thin as in for the fluid layer right now, because we want to keep a thin fluid layer to maximize the amount of oxygen getting to the cornea, and we want to minimize that fluid layer if debris gets into it, because the thinner fluid layer, the debris is less noticeable. So scleral contact lenses have solved the comfort problem with gas-permeable lens materials. Truly has. I find these lenses quite often, patients find them more comfortable than soft lenses and soft torics. I wear the lenses myself, and I find that to be the case. But there are potential challenges, and these lenses require our expertise, our continued care, and our vigilance. So I'd like to thank you, and are there any questions?
Yes. Dr. Burns, questions have come in. This we could probably get in a couple of them as it takes us up to. So let's try this one first. How would you instruct a patient who just put on a scleral contact lenses to check for bubbles underneath the lens?
Okay, well, as I said earlier, bubbles create 2 issues. One is a vision issue. If the bubble gets into the visual axis, it's going to degrade significantly the visual acuity. And and that's annoying, and the patient's going to notice that right away. But if the bubble's off center, it's not in the visual axis, if the patient, it can be easily missed even if the patient's looking for the bubble. But sometimes you don't have a mirror available and you can't take a look. So be aware of the symptoms of a bubble. The symptoms of the bubble are the dead giveaway. When the eye starts to feel like there's burning, stinging, irritation, that irritation is caused by the surface of the cornea drying out. And the only cause that you can have for the surface of the cornea to start drying out after about 10 or 15 minutes of lens wear is there's a bubble there. So use that as a reason to remove the lens, refill the lens with fresh, non-preserved saline, and apply the lens again to the eye. And if 5 or 10 minutes later you get that same feeling, you're still getting a bubble. Patients who are new to using these lenses are not really adept at putting these lenses in successfully every time. I've worn scleral lenses for over 10 years, and I get bubbles every now and then, and I put lenses on patients every day. So it's not only a skill, but it's something that happens whether you're the most skillful or not. So if you're getting discomfort, remove the lens, you had a bubble.
Okay, for another one, how do you determine the lens diameter of a scleral lens that you wish to use on a patient?
And that's interesting, particularly in light of Kinograph and Caroline study. We know when we fit further away from the limbus, we get more scleral asymmetry. Well, we also have patients that have a large variety of horizontal visible iris diameters. We have large corneas, we have small corneas. So what I do is I look at the horizontal visible iris diameter, and I know that I want to have a lens fit a certain distance beyond that. So if it's a 14 millimeter cornea, I know that I want to be half a millimeter beyond the limbus before I start touching the conjunctiva, and I want to have a fitting zone of at least a millimeter in width. And so that'd be 14 plus half and half is 15 plus 1 on each side. I'd be going to a 16 millimeter lens. Smaller cornea would be different. Now people say, well, I don't want to do all that math and I'm not going to remember that. Well, an easier way is you just put a contact lens on your eye, put your favorite trial lens on the eye, and look how far away you are from the limbus. Ensure that your landing zone that you can visualize is not crossing the limbus or bearing on the limbus. And if it's too far but you're getting a nice alignment zone, if it's a good distance away from the limbus, go ahead with that diameter. But if you're not fully covering the limbus and you're getting impingement or you're getting the lens bearing on the cornea, you need to go to a larger diameter. So put the lens on and take a look.
Dr. Burns, thank you for presenting today's webinar. I'd also like to thank each one of our attendees for coming on and learning more about what you had to say. I would like to encourage each one of you to work with your individual independent laboratory that manufactures the scleral lenses. They have consultants, customer service people, and the actual creators, the research and development teams at each one of these labs that can walk you through each one of their designs. We have some great ones on the market, and the scleral market has truly exploded. I would encourage you to work with them. I want to thank you again for attending the Contamac presented seminar, and just wish you a great day. Take care.